Hi, good morning, doctors. Today we are on a 33rd day of reading Oxford Handbook of General Practice. I am Dr. Sesha, your study buddy, and we are preparing together for MRCGP AKT exam. Let's start reading. Yesterday we were reading dermatology, and today we will continue dermatology further. Today we will continue from page number 572, pigmentation disorders. Albinism. Albinism, the prevalence is 1 in 20,000. It's a rare genetic syndrome, autosomal recessive in inheritance, in which the melanocytes are unable to produce skin, hair, or eye pigment. Patients have white hair, pale skin, pink eyes, poor sight, photophobia, nystagmus. Several different varieties exist. Management: strict sun avoidance, sunglasses, sunscreens. Refer any skin lesions for biopsy because there is increased risk of squamous cell carcinoma. So these are the pictures. This one is chloasma of the cheek. This one is albinism. You can see there is a difference in pigmentation on this part of the forearm to this part of the forearm. Vitiligo. This is vitiligo. And albinism is, let's see the differences between both. Vitiligo affects only 1% of the population. That's more, 1 in 100. Males and females, there is equal predominance. Peak age of onset is 10 to 30 years. Causes are autoimmune. 18% have a family history of vitiligo. Associations with diabetes, alopecia areata, pernicious anemia, Addison's disease, and thyroid disease. So these are all autoimmune conditions. See, diabetes, alopecia areata, pernicious anemia, Addison's disease, thyroid disease. These are all autoimmune conditions, and there is association with vitiligo also. Presentation may be precipitated by sun injury or sunburn. Whenever there is injury or sunburn, the skin again becomes pale. Presents as smooth, sharply defined white macules or patches which contain no melanocytes. Skin appears bright white under woodlights. Bright white under woodlight if available. Often symmetrical distribution is there. Hair may be affected. Most common sites are hand, the wrists, the knee, the neck, face, around the eyes, and mouth. So this one is vitiligo. See, there is a symmetrical distribution and it is completely white. Differential diagnosis. Post-inflammatory hyperpigmentation can also present as hypopigmentation, but there won't be any bilateralness here. Pybaldism. Pybaldism is a tuft of hair that is the forelock will be white. Pityriasis alba. You'll have hypopigmented fur tree appearance patches. Chemical exposure or leprosy. Leprosy can also be hypopigmented. So these are the differential diagnosis. Management. Prognosis variable. Spontaneous remission is unusual. Often pigment loss is progressive. Advise the use of a high factor sunscreen for affected areas. ACBS prescription. Camouflage cosmetics. Refer for changing faces for advice on application. Refer to changing faces for advice on application. ACBS prescription. Consider refer to dermatology for consideration of topical steroid, topical calcineurin inhibitor, that is tacrolimus, pimecrolimus, unlicensed, or a narrowband UVB, TLO1 phototherapy. Narrowband UVB phototherapy helps 6-7%, but relapse may occur after treatment ends. So, in case of vitiligo, you can use topical steroid, topical calcineurin inhibitors, or a narrowband UVB phototherapy. Morphia is localized scleroderma. Female to male ratio is 3:1. Cutaneous localized form of scleroderma, pathologically distinct from lesions of systemic sclerosis. Internal disease is not associated. Cause Autoimmune, but not fully understood, may follow a trauma. Patients with round oval plaques of induration and erythema which become smooth, shiny and white with violet borders. Okay, this very good description. Round oval plaques of induration and erythema become smooth, shiny white with violet borders. Eventually, leaves atrophic hairless pigmented patches. Affects the trunk and proximal limbs. No established treatment. Usually resolves spontaneously in 3 to 5 years. Potent topical steroids may be tried. Hair and sweat gland problems. Hair loss or alopecia. Treat according to the cause of hair loss. Differential diagnosis. Diffuse non-scarring alopecia, male or female pattern baldness, telogen effluvium, localized non-scarring alopecia, that is alopecia areata, ringworm, chirion may scar, traumatic, hair pulling, traction, SLE, secondary syphilis. Scarring, alopecia due to burns, radiation, shingles, tertiary syphilis, lupus erythematosus, morphea, lichen planus, chirion, folliculitis, decalvans. Okay, these are causes of scarring alopecia. Whenever there is a burn, there will be alopecia, radiation, shingles, tertiary syphilis, lupus, morphea, lichen planus. Okay, lichen planus also has a scarring alopecia. Chirion is again this ringworm, may cause scarring alopecia, and folliculitis decalvans. Telogen effluvium, acute onset, occurs 3 months after a trigger factor, a trigger like pregnancy, fever, surgery, weight loss, crash diet, stress. If the trigger is not repeated, hair regrows in 3 to 6 months. Chronic, occurs in middle-aged females, cause is unknown, large amounts of hair shedding but appearance of a normal head hair. So this is chronic telogen effluvium, middle-aged females. Normal head hair will be there, but there is large amount of hair shedding. Only reassurance you have to give. Secondary telogen effluvium. Check the FPC's ferritin thyroid function test. Cause may be an endocrine cause, hypothyroidism, hypopituitarism, hypoadrenalism, drug-induced causes, example chemotherapy, nutrition causes, iron deficiency. Treat if ferritin is less than 40 micrograms per liter and there is any zinc deficiency. So this is secondary telogen effluvium. Pattern baldness affects males at any age, androgenic alopecia, and usually postmenopausal females. Strong genetic predisposition for a female if evidence of virilization, acne or hirsutism. Further investigation is needed. If there is acne, hirsutism and again pattern baldness in a female, you have to investigate further. Treatment options. No treatment is there for pattern baldness. Hair products containing, you can use a big hair products containing nanofibers to make hair appear thicker. Topical minoxidil thickens or increases the density of the remaining hair. Use 5% foam or solution for males, 2% solution for females. Give a 6 to 12 months trial. Helps 40% of the cases. Finasteride for male patients only. 1 milligram OD or 5 milligrams per week. Reassess after 6 months. Helps in 2/3 of the cases. Spironolactone. Only female patients. 50 to 200 milligrams daily plus minoxidil decreases the hair loss in 75% of the cases. Surgery. Follicular unit transplantation. Variable outcomes are there. Drug treatment is not available on the NHS prescription. Effect is lost if the treatment is discontinued. Surgery is not available through the NHS. So hair transplant surgery, that which they were saying. Alopecia areata, common autoimmune disease affecting the follicles plus nails. 10% causes spitting. 20% have a family history. Patches of hair loss usually on the scalp but can affect any hair bearing skin. Short broken exclamation mark hairs are seen at the margins of the active area of alopecia. Yellow dots may be seen around the hair follicles. Consider alternative diagnosis of tinea capitis if scales or erythema is present. Management. Investigation is usually unnecessary. If mild hair loss, reassure and monitor hair loss. If more severe, refer to dermatology. Specialist treatment options include topical or locally injected systemic steroids, topical, locally injected or systemic steroids plus contact immunotherapy. So 40% recover in less than 1 year. 20% lose all scalp hair. Recovery in these cases is unusual, less than 10%. Psychological support may be needed. Hirsutism. Excess hair in the androgenic distribution. So hirsutism is different and virilization is different. Hirsutism is excessive hair in the androgenic distribution. Hypertrichosis. We will see, we have read about hirsutism in 312. Hypertrichosis. So hirsutism and hypertrichosis. Excess hair in non-androgenic distribution is hypertrichosis. Usually the face and the trunk, though, can be generalized, mostly drug-induced. So hypertrichosis is drug-induced, hirsutism is hormone-induced. Mostly drug-induced, phenytoin causes hypertrichosis, cyclosporin and minoxidil. If not, investigate to find other causes of malnutrition, anorexia nervosa, porphyria cutanea and malignancy. If a cause cannot be found, treat symptomatically with electrolysis, bleaching, waxing or depilatories. For hypertrichosis, you can treat with local treatments like electrolysis, bleaching, waxing and depilatories. Local hypertrichosis can be associated with topical steroid usage, be over a melanocytic nevus or associated with spina bifida occulta. So this local tuft of hair will be present in melanocytic nevus or spina bifida occulta. Hidradenitis suppurativa. Chronic autoimmune inflammatory condition of the sweat glands in the axilla, the groin or the perineum. So only in the axilla, groin and perineum, it's an autoimmune inflammatory condition of sweat glands. Females more than males. Maybe a family history can be present. Nodules, abscesses, cysts, sinuses form. Scarring is present. Treat with topical antiseptics, 4% chlorhexidine wash or antiseptic emollients like Dermol 500 lotion, systemic antibiotics, limicycline 408 milligrams OD, plus or minus surgical drainage or excision. Refer to dermatology if these measures fail. Hyperhidrosis. Sweating or perspiration is normal and essential for the temperature control. The amount people sweat varies enormously. Usually sweating can be controlled with sharp, broad antiperspirants and is only excessive when it cannot be controlled and interferes with the patient's quality of life. So hyperhidrosis is normal and essential for temperature control, whereas sweating is normal, whereas the amount of people sweat varies enormously. Usually sweating can be controlled with sharp broad antiperspirants. Only excessive when it cannot be controlled and interferes with the patient's quality of life. Excessive sweating may be focal or generalized. So generalized hyperhidrosis most likely secondary to other medical conditions where possible treat the cause. Physiological causes. After or during an exercise, hot humid conditions, emotional response that is anxiety, infection can occur with any bacterial or viral infection. Consider malaria if recent travel history is present. Non-infective causes. Menopause, Parkinsonism, diabetes, thyroid toxicosis, pheochromocytoma, lymphoma, leukemia, drug or drug withdrawal. So these are the conditions where there is generalized hyperhidrosis. Menopause, Parkinsonism, diabetes, thyrotoxicosis, pheochromocytoma, lymphoma, leukemia, drug or drug withdrawal. If no cause is found, consider prescribing propanthelin 15 milligrams OD or 30 milligrams thrice daily. 30 milligrams thrice daily. Alternatives, all off license, include oxybutynin, modified release 10 milligrams per day, propranolol TDS, diltiazem 60 milligrams TDS. May take 6 weeks to work. So these are the medicines we will be prescribing for generalized hyperhidrosis. Propanthelin 15 to 30 milligrams, 50 milligrams OD to 30 milligrams BD, TDS, oxybutynin propranolol, diltiazem, and any of this will take 6 weeks to work. Focal hyperhidrosis affects 5% of the population, usually primary condition, mainly affects the axillae, the palms, the soles of the feet or the face. Onset is typically in the teenage years, distressing and socially disabling. Advice for the patients. Avoid clothing made of elastane, nylon or other man-made fibers and tight clothing. Wear colors that do not show the sweat, white or black. Use emollient washes or moisturizers rather than soap. Identify trigger factors for sweating, alcohol, crowded rooms, and avoid those situations. Specialized products may be helpful. Treat topically with 20% aluminum chloride. So when there's localized sweating, 20% aluminum chloride and hydrol fort. Apply to clean skin at night and wash off in the morning. This decreases decrease the frequency of applications as the symptoms subside. Aluminum chloride. Treat local irritation with topical steroid. Whenever this aluminum chloride is causing local irritation, you treat with topical hydrocortisone 1%. Absorbent dusting powder may help axillary or plantar sweating. Consider a trial of drug therapy as for generalized hyperhidrosis. We were using propanthelin, oxybutynin, propranolol or diltiazem. Refer to dermatology if not responding. Specialist treatment. What does the specialist do for hyperhidrosis? Ionotophoresis, botulinum toxin injections, endoscopic transthoracic sympathectomy for severe palmar hyperhidrosis. So the next chapter is nail changes. Next topic is nail changes. Page number 576. Nail changes may be due to nail disease or indicate other dermatological systemic diseases. Assessment. Take a history. Duration. Initial changes, evaluation of changes, other systemic or local symptoms, family history, drug and alcohol history, occupation and hobbies. Examine. Examine the color, the shape, the extent and pattern of involvement. Consider examination or investigation for other skin or systemic diseases guided by history and appearance of the nails. Nail changes, description and causes. Color. Black transverse bands are present due to cytotoxic drugs. Blue nail discoloration because of can be because of cyanosis, anti-malarial drugs like chloroquine, hematoma, phenothiazines, Wilson's disease. Phenothiazines and Wilson's disease. Blue-green discoloration of the nail is due to Pseudomonas infection. Brown discoloration of the nail. Fungal infection, cigarette staining, chlorpromazine, gold, Addison's disease. So Addison's disease, there will be generalized hyperpigmentation of the creases as well as the nails. Brown pigmentation of the nails. Gold, fungal infection, cigarette staining and chlorpromazine. All of these can cause brown pigmentation. Brown oil stain patches seen in psoriasis. Brown longitudinal streaks. Now this is longitudinal and brown. Melanocytic nevus, malignant melanoma, Addison's disease. Again, Addison's disease can have longitudinal streaks also, whereas other two causes are melanocytic nevus and malignant melanoma. So if there is brown longitudinal streaks on the nails, think in lines of melanocytic nevus or malignant melanoma. Red streaks, splinter hemorrhages. Splinter hemorrhages is seen in infective endocarditis, other vasculitic diseases and trauma. White spots on the nails, trauma to the nail matrix. White transverse bands. Now there is transverse bands which are white, that is heavy metal poison, whereas black transverse bands were there in cytotoxic drugs. White or brown half and half nails, chronic renal failure. Half and half nails, white and brown, chronic renal failure. White nails, that is leukonychia. Hypoalbuminemia associated with cirrhosis. Yellow nails. When do you have yellow nails? Many conditions. Psoriasis, fungal infection, jaundice, Raynaud's disease, tetracycline use, immunodeficiency, tuberculosis, bronchiectasis, sinusitis, nephritic syndrome. Yellow nail syndrome, defective lymph drainage, nail grows very slowly and may be associated with pleural effusion. Brittle nails. Nail breaks very easily, usually at the distal end. Effect of water and detergent, iron deficiency, hypothyroidism, digital ischemia. So brittleness causes are iron deficiency, hypothyroidism, digital ischemia, and water and detergent. Clubbing. So clubbing is one of the nail changes. Refer any patient with unexplained clubbing for urgent chest X-ray. Loss of angle between the nail fold and the plate, bulbous fingertip, nail fold feels boggy. So conditions of clubbing: respiratory, bronchial carcinoma, not small cell carcinoma, chronic infections, fibrosing alveolitis, asbestosis, cardiac causes, subacute bacterial endocarditis, congenital cyanotic heart disease. Other causes: inflammatory bowel disease, cons more than ulcerative colitis, so C for cons and C for clubbing, thyrotoxicosis, biliary cirrhosis, congenital causes, and AB malformations. These are the causes of clubbing. Koilonychia, spoon-shaped nails. Physiological in children, especially big toenails. Congenital, most common. Of other causes are of koilonychia: iron deficiency anemia, lichen planus, repeated exposure to detergents, and hemochromatosis, Raynaud's disease, diabetes. So koilonychia causes could be iron deficiency, lichen planus, repeated exposure to detergents, hemochromatosis, Raynaud's disease, and diabetes. Onycholysis, separation of the nail from the nail bed. Onycholysis is seen in psoriasis, fungal infections, trauma. Thyrotoxicosis, tetracycline. Light photoonycholysis secondary to doxycycline use. Pitting in the nails. Fine or coarse pits in the nail bed. Psoriasis, eczema, alopecia areata, and lichen planus. Bew nail, blue lines, BEAU, Bew's lines, transverse grooves. Any severe illness which affects the growth of the nail matrix. Ridging, transverse ridging is seen, it could be Bew lines, eczema, psoriasis, chronic paronychia, habit tick dystrophy, thumb more than other fingernails due to habitual rubbing or picking at the cuticle. Longitudinal ridging, lichen planus, Raynaud's disease, Darier's disease, that is keratosis follicularis, genetic disorder appearing in adolescence, mainly affecting the skin and nails. So lichen planus, Raynaud's disease, and Darier's disease. Nail fold telangiectasia. The dilated capillaries and nail fold erythema. Normal change of aging, corrective tissue disorder could be there. Tumors of the nail fold, benign. Viral warts, myxoid cysts, treat with steroid injection, cryotherapy or surgical excision. When there is myxoid cyst, periungual fibroma associated with tuberous sclerosis appears at puberty. Malignant tumors of the nail fold, melanoma and squamous cell carcinoma. Page number 578, atopic eczema. Affects 15 to 20% of the school children, atopic eczema, 2 to 10% of adults. Usually starts less than 6 months of age, and by 1 year, 60% of those likely to develop eczema will have done so. Associated with filaggrin gene mutation and other atopic conditions, remission occurs by 15 years of age in 75%. Okay, although some relapse may occur later. Differential diagnosis could be scabies, ringworm, rare syndromes, example Wiskott-Aldrich syndrome, or dermatitis herpetiformis. Presentation: waxing and waning itchy condition. If no itching, eczema is unlikely. Infants. Infantile eczema. Presentation varies in severity from minor roughened patches of skin to itchy vesicular exudative eczema on the face, trunk, hands. Secondary infection may cause sleep disturbance. More than half are free of eczema by 18 months of age. In children, that is infants, in children more than 18 months, involves the antecubital and popliteal foci, flexures, neck, the wrist, and ankles. Lichenification, excoriation, and dry skin are common. Face may be erythematous and have typical infraorbital folds. Loss of self-esteem and behavior and sleep problems are common in children more than 18 months old. Adults, most commonly irritant hand dermatitis in a person with a past history of atopic eczema. A few continue to have generalized atopic eczema. Less than 2% develop new eczema aged more than 20 years. May interfere with employment or social activities exacerbated by stress. Diagnosis: itchy skin plus more than 3 of the following. Itching in the skin creases, generally dry, history of asthma or hay fever, visible flexural eczema, onset in the first 2 years of life. So there should be itchy skin plus 3 of the following: either itching in the skin creases, history of asthma or hay fever, onset in the first 2 years of life, generally dry skin should be present, visible flexural eczema. Assessment: ask about family history and personal history of atopic or eczema, onset and distribution of the disease, aggravating factors like pets, irritants, soap, detergent, allergens, sleep disturbance due to itching and rubbing, impact on the quality of life, school, work, career, social life, previous treatments including dietary restrictions, expectations of treatment and medications being taken like steroids for asthma. So nipple eczema may be Page's disease of the breast. 674. Refer urgently to a breast surgeon if no response to topical treatment. Complications: skin thickening and scaling, bacterial infection, secondary infection usually with staph, commonly causes exacerbations and may not be obvious, suggested by the presence of crusting or weeping or sudden deterioration of eczema. Viral infection, increased susceptibility to infection, viral warts, molluscum, eczema herpeticum, propensity to develop widespread lesions with HSV and varicella zoster virus with atopic eczema, BZV or HSV, and may require admission and IV acyclovir. This concept was again tested in the exams. Cataracts rarely occur in young adults with very severe eczema. Growth retardation. Children with severe eczema, cause unknown. Keep a growth chart for children with chronic severe eczema. So cataracts rarely occur in young adults with very severe eczema, and growth retardation can be there in children. So this one is infantile eczema on the face and cheeks. See, there is already a groove in the under eye. Again, this is on the knees. Childhood eczema involving, no, this is a popliteal foci. Childhood eczema involving both the popliteal foci. This is hand or eczema or contact dermatitis in an adult. Page 580, management of atopy. Education. Explain the condition and provide verbal and written information on a stepped approach to care, management of flares. Advice. Loose cotton clothing. Avoid wool, exacerbates eczema. Avoid excessive heat. Keep the nails short. Gloves in the bed to prevent any uh, skin problems due to itching. You have to keep the nails short. If there is a specific irritant is identified like house dust, mite or pets, then avoid them. Specific treatment. Emollients. Specific treatment by emollients. Topical creams or ointments and bath emollients used regularly on the skin as soap substitutes even if clean skin is clear. So you need to use topical creams or ointments and bath emollients as uh, the on the skin as soap substitutes even if the skin is clear, that is even if there is no eczema at that time. May need to try several to find one that suits. Ideally apply 3 to 4 times a day to moist skin. Ensure enough is supplied. Addition of an antipruritic, example lauromacrogol, to the emollient may help break the scratch itch cycle. Addition of an antiseptic to the bath emollient may decrease the bacterial infection. Topical steroids. Prescribe the least potent strength that is effective. Use OD or BD. Ointments are preferable on dry eczema. Creams on wet executive eczema. So ointments are preferable on dry eczema and creams on the wet executive eczema. Recurrent flares. Once the flare settles, consider 2 times weekly topical steroids as maintenance. Antibiotics. Flucloxacillin 250 or 500 milligrams QDS for 7 days. Only use if a flare is not responding to increased topical steroid regimen. Swab if antibiotic treatment is ineffective. Oral steroids. Rescue therapy while waiting for an urgent consultant opinion. Use short courses. Prednisolone 20 to 30 milligrams OD for 5 days. Topical immunosuppressants. Pimecrolimus cream or tacrolimus ointment. Antihistamines. Short course sedative antihistamines given nocturne to decrease the desire to age. Promethazine or hydroxyzine. Bandages. So, hydroxyzine or promethazine are sedative antihistaminics used to decrease the itch. Bandages. Excoriated or lichenified eczema. Ictamol. Example, Ictaband or zinc and calamine, Calaband. These are bandages. Bandages can be applied at night on the top of a steroid ointment. Refer to dermatology. Wet wrapping. Used for exudative eczema, elasticated tubular bandage or tubular gauze soaked in emollient is applied and covered with a dry bandage. Refer to dermatology. So, used for exudative eczema, elasticated tubular bandage or tubular gauze soaked in emollient is applied and covered with a dry bandage. Refer to a dermatology. Dietary manipulation. Few less than 10% benefit. Egg and milk are most commonly excluded. Refer to a dietitian to avoid malnutrition. Referral causes conditions for referral. Infection with disseminated HSV, eczema herpeticum is an emergency referral for IV acyclovir. Severe eczema resistant to treatment, additional secondary care treatments include phototherapy and immunosuppressive drugs. That's an urgent referral. Infection which cannot be cleared in primary care, urgent referral. Severe social psychological problems due to eczema, soon. Treatment requires excessive amounts of topical steroids, soon referral. Failure to control symptoms in primary care, routine referral. Patient or family might benefit from additional advice of application of treatments like bandaging techniques, refer is routine referral. Patch testing required if contact dermatitis is suspected. So for patch testing, you have to do a routine referral. Dietary factors are suspected. Refer direct to a dietitian, that is routine referral. Prurigo nodularis or nodular prurigo. Intensely itchy firm lupus 1 to 2 centimeters in diameter. Cause unknown, but 80% have a history of atopy. Exclude scabies and systemic causes of itching. Treatment. Topical steroids. So the firm lumps, these are intensely itchy firm lumps 1 to 2 centimeters in diameter. Causes unknown, but 80% have a history of atopy. Exclude scabies, systemic causes causing itching. Treatment is topical steroids and occlusion. May need sedating antihistamine for itch. Contact dermatitis is precipitated by an exogenous agent which is an irritant. So irritant contact dermatitis like water, abrasives, chemicals or detergents, or allergen. Example, nickel 10 to 10%, 1% in males, chrome, rubber. So nickel maximum, chrome or rubber allergy. Clinical presentation is often indistinguishable, more common in patients with past history of atopic eczema. In some patients, contact dermatitis may be an industrial disease. Differential diagnosis, endogenous eczema. So whenever you have contact dermatitis, you have to differentiate with endogenous eczema, psoriasis or any fungal infection. Presentation. It affects any part of the body, more commonly contact dermatitis affects any part of the body, more commonly the hands. Sight and knowledge of occupation, hobby, sport, etc. suggest a cause. Acute contact dermatitis, itchy erythema and skin edema plus papules, vesicles or blisters. Chronic, there is lichenification, scaling and fissuring. Management, identification of the allergen or the irritant. Consider referral for patch testing. So since contact dermatitis is a type 4 hypersensitivity reaction, you refer for patch test. rather than prick test. Exclusion of allergen or irritant from the environment. If possible, there is some evidence that nickel avoidance diets can help the patients with nickel sensitivity. So nickel present in the diet also. So nickel avoidance diet helps with nickel sensitivity. Nickel testing kits are available from dermatology department. Hand care. Table 16.5. Emollients help the skin to recover. Apply frequently. Topical steroids help but are secondary to avoidance measures. Exclude treat secondary infection. Exclude or treat secondary infection. Hand care. So hand care in dermatology. Hand washing. Use of warm water and soap substitute with emollient. Substitute soap with emollient. Example, aqueous cream. Dry with clean cotton towel. Avoid paper towels or drying machines. Avoidance. Avoid handling hair preparations including shampoos, other detergents, household or industrial cleaning fluids, raw vegetables, example peeling potatoes, tomato juice, fruits, peeling oranges or raw meat. Protection. If performing any task where hands would get wet or any of the substances listed previously in the table are handled, wear cotton gloves under PVC gloves. So you wear first cotton gloves and then wear PVC gloves because again PVC gloves can cause allergy. So wear gloves for dusty work or in the cold. Medication. Use emollients frequently throughout the day. Dipro-based cream. If necessary, apply a thin layer of steroid ointment, OD or BD. For further information on atopic eczema in children under 12, please follow the link. Page number 582, other eczemas. Discoid or nummular eczema, seen in middle-aged elderly patients, males more than females, unknown cause. Discoid or nummular eczema. Presentation. Intensely itchy coin-shaped lesions on the limbs, tends to be symmetrical, may be vesicular or chronic and lichenified. So bilateral coin-shaped lesions on the limbs. Differential diagnosis could be tinea corporis, contact dermatitis or psoriasis. Management often clears spontaneously over few weeks but tends to recur. If treatment is needed, use a moderate or potent topical steroid. Secondary infection is common. Treat with topical or systemic antibiotics. A sedating antihistamine, hydroxyzine 50 mg nocturne may be useful if sleep is disturbed by itching. Venous chassis, varicose eczema. Middle-aged or elderly patient, female more than male. So varicose means more common in females, associated with underlying venous disease. Early signs of varicose eczema, capillary veins and hemosiderin deposits around the ankles over prominent varicose veins. So there will be hyperpigmentation, hemosiderin deposition. Later signs, eczema plus lipodermatosclerosis, fibrosis of the dermis and subcutaneous tissue plus ulceration. So there will be this thickening of the skin called as lipodermatosclerosis later on. Management, emollients plus mild moderate steroid ointment, avoid long-term use. So how do you manage varicose eczema? You give them emollients plus mild or moderate steroids and avoid long-term use and ask them to wear a compression hosiery. Treat the venous disease or ulceration on its own merits. Pomphilox. Sago-like intensely itchy vesicles on the side of the fingers, palms and soles. No associated atopic eczema or contact dermatitis. Young adults more, more common in warm weather. Frequently recurrent. Treat with emollients and topical steroids. Some need potent topical steroids. Treat any infection with oral antibiotics. If severe cases, refer to dermatology for wet dressings. This is Pomphilox. Lichen simplex chronicus. Area of lichenified eczema due to repeated rubbing or scratching, may be due to habit or stress. Treatment. Take the scrapings to exclude fungal infection. Topical steroids. Give them topical steroids and occlusive dressing like Duoderm to protect skin from scratching. Lichen simplex chronicus. So this one is varicose eczema. So look at the bluish hemosiderin deposition, lipodermatosclerosis, and excoriated eczematous lesions and lipodermatosclerosis. Asteatotic eczema. Eczema craculi. Asteatotic eczema. Risk factors: increased age, overwashing, dry climate, hypothyroidism or diuretics. Presentation: dry, itchy eczema with fine crazy paving pattern of fissuring and cracking of the skin or limbs. So crazy paving pattern and fissuring or cracking of the skin or limbs. Management is treat with emollients plus mild topical steroid. It is asteatotic eczema, mostly seen in the elderly people. So we'll stop here for today, doctors. We are at page number 583. Tomorrow we will continue from seborrheic dermatitis. Thank you. Have a good day.